All right. Well, I'm sure at this point your brains are all very full. So we're going to kind of go from a Chopin piano concerto to chopsticks here. So hopefully I can play chopsticks well. Now, weight craniotomy, a little different than a Hollywood dramatization here. We're not eating brains, of course, but initially this was all about localization. For the brain path technique, it's as much about your interaction with the brain. And the reason to do these awake is that interaction and changing some of your actions as a surgeon. I'm sure most of you all are familiar with these techniques. So mostly I'm going to talk about what I do, how I do it, and just developing a comfort level with doing awake craniotomies. Now, for localization, of course, traditionally, this has been motor and sensory, speech, but also vision during these cases. Now, some of the tips involve patient selection, anatomy. Where is the lesion? How are you going to approach it? Different pathologies. The personality of the patient weighs in greatly on doing this. Are they going to tolerate an awake case? Are they going to be helpful during the case? What I do when I talk to patients is I tell them, you can help me do this operation. You're an integral part of this surgery. And often that gives them a greater comfort level of doing it. Also, we'll go through OR setup, anesthesia, or mostly analgesia during these cases, and your testing during the case. Now, for patient selection, mostly this is done when there are lesions adjacent to or near eloquent areas, or if you're going to be traversing certain white matter bundles, tracts, in areas of interaction, or newer concepts that we're developing now. And I'm very interested in how to integrate this with the connectome. That's something that I'd like to talk with you about more, Michael. Sometimes for smaller lesions, being able to approach these lesions with the port. Now, for the most part, this is going to be using it with non-dural based lesions, in part because it's difficult to control pain with the dura to anesthetize it. It's great for gliomas, metastases. I do awake cases too with cavernomas because it's really about your interaction with the surrounding brain rather than the pathology itself. The patients have to be able to deal with the stress of going through this surgery. So again, personality has a lot to do with it. I've used this technique with very young patients. Some teenagers actually do fairly well when we talk about how they're able to help with the case. And in one case, I actually let him have his cell phone and said, you can text your parents during the case to tell them how you're doing if that makes you feel better. And he actually did. This is a 14-year-old with a thalamic tumor. So with the MIPS technique, working through a small cortical opening, mapping the cortex is not always practical, but you can do subcortical stimulation and do that through the port. Now you can stimulate the adjacent cortex prior to cannulation, but once you cannulate, generally, there's really not much room around that. So your stimulation is instead going to be subcortical. For your setup in the OR, you always have to think about your primary working direction. And this is really for doing a MIPS case in general, but it does add a few nuances to your setup with doing a wake case. Where is anesthesia going to be? Where is your back table going to be as far as passing instruments? And where are your examiners going to be for examining the function during the case? These are all the things that you want to lay out ahead of time so that you're not having to make adjustments during the operation itself. Now, for primary working direction, this was a case with parietal metastasis. When I plan out the case, I'm going to be working from superior to inferior and kind of a bit lateral to medial. So that's going to determine how I set up the room for the case. And here we are with the tumor that you can see is just behind motor fibers and motor cortex. So here's our OR setup. And you can see I'm working from superior to inferior, so I'm placing the monitor at the foot of the bed so that I can sit comfortably, look the same direction that I'm working. And of course, having the patient comfortable during the case, not turning the head too much, having them in a very relaxed position. So we will give them a little extra dose of propofol before pinning. I use the synaptive system, so we don't have an EM component to this, so all my patients are in pins. But then I have them wide awake, talking to them, are you comfortable? This is a key part during the case, is making sure they're comfortable. Otherwise, what happens is that people kind of start squirming a bit during the case, and you get a lot of movement, and then it's what I call earthquake surgery, with this constant movement as you have a patient trying to get comfortable. Another little adjunct, make sure they don't have a little cold or a cough before you do this case. The most miserable awake case I did was with the patient who did have a cough. This is happening constantly during the case and made it almost undoable. Now, when you look at the slide on the right, I use the shower curtain. This is a hip drape that allows me to, see the screen beyond the patient. And it also allows us to navigate and have my navigation arm in front of the drape. And so it's great for visualization. I found to be really helpful. Another thing I do is I ask patients, do you want to watch? I find about 2/3 of them do want to watch during the case, and they can actually help because we're asking them questions or having them make comments. I'm feeling this, or I'm noticing this when you're working in this particular area. So it can be very helpful during the case because you're not able to test them continually, but having that direct feedback from the patient, I found is very helpful. For the anesthesia, there are different ways of doing this. There's the asleep, awake, asleep way of doing the cases where you actually have them fairly sedated, possibly with an LMA, then awake during critical portions of the case and asleep at the end. I tend to do an awake, awake, awake approach where they're sedated somewhat for pinning. And by the time I'm doing the craniotomy, we have them really wide awake and awake during most of the case, and then lightly sedated at the end. Using propofol or Precedex as our hypnotic sedative agents, and then remifentanil as a general analgesic. You can do this with either regional blocks or local infiltration. Regional blocks are very helpful if you have someone that's familiar with it. I myself am not, my anesthesiologists aren't, so I tend to use local infiltration rather than regional blocks. With MIPS cases, here we are, the regional anesthesia map. The great advantage of this is you can anesthetize essentially the entire scalp for these cases. So it's great for putting in the pins as well as doing the case. But again, I don't have these capabilities available to me, so I use a local infiltration. One key tip with doing this local infiltration is you want to infiltrate widely. So not just where you're making the incision, but any muscular dissection and periosteum beyond that also. So I use a mixture of half and half, 2% lidocaine with epinephrine and 0.5% bupivacaine. This gives me a number of hours of analgesia during the case, but also that immediate analgesia for pinning especially. Infiltrate subcutaneous in the periosteum, both for the pin sites and incision sites. And I also keep some 1% plain lidocaine for soaking pledgets to put over the dura after I do the craniotomy. When I trained, we'd actually try to put a needle between the leaves of the dura and infiltrate that way. It's a whole lot easier just to put some cottonoids over it after you do the craniotomy. As I'm setting up my retractors and everything for the brain path, I have that time to anesthetize the dura itself. The stimulation, do cortical stimulation prior to cannulation, especially if you're working right near the motor strip or sometimes near Broca's area. And subcortical stimulation also can be very helpful during the case, and you can do that through through the port and do this as you're working, especially with tumor resection. Show you a few case examples. The first one's a 61-year-old woman with metastatic melanoma who presented with progressive and really severe expressive aphasia. Our MRI showed this enhancing left frontal lesion. As you can see here, this is kind of sitting right under Broca's area and just subcortical. Now, you might ask, why even do this with the MIPS approach with the lesion that's this superficial? Well, it's in part because now I have a nice radial retractor to use, not putting pressure on that surrounding cortex, and I can adjust that during the case as needed. So we did this with the MIPS approach, as I described previously. Total operative time from putting on the pins to the dressing was 68 minutes. And this is in part, these approaches with the port are very quick getting into the lesion. I cannulated deep to within it, having her speaking as I was cannulating. And what I found was that even very small changes in the angle of the port did affect her speech. So my first cannulation, her speech got a little bit worse. I just changed the angle a little bit and would wait a few minutes and it improved. And so I used that to adjust exactly how I had the angle of the port as I was working, because as I resect the lesion, there's less pressure on that surrounding cortex. I can then readjust the port and continue working. So here's our setup in the OR. This is someone who said, yeah, I really don't want to see this. I don't want to watch. So I positioned the monitor so it wasn't directly in front of her, but it put me in a nice operating position, very comfortable, looking down toward the monitor with my navigation to the left. Here again, you can see the setup. I use that bar on the side to open the drapes over her face for both anesthesia and my testers that come in, usually occupational therapy or physical therapy. For this case, I was speaking to her during most of it, have her talking, saying different phrases, reading cards as we're doing the case. So intraoperatively, again, her speech was mostly fluent. There are no changes initially, a little bit during cannulation, no changes during resection. And here's our post-op MRI, just a little bit of hemorrhage posteriorly. As you can see, the cortex mostly left undisturbed with that nice cavity. And if you're using the myriad, at the edges of the lesion, often you'll find there's very little hemorrhage from the surrounding white matter. So not using the bipolar, I think, gives you a lot less post-op edema. I try to be very judicious with my bipolar use, mostly using either Surgicel Fibrillar or Flow Seal, cottonoid patties for a little bit, direct bipolar only when there are active bleeding from small vessels, but not when there's just a bit of oozing. So I see less edema post-op than I do pre-operatively. So by post-op day 1, her dysphagia was nearly completely resolved, and she was discharged to home 30 hours post-operatively. People feel a lot better post-operatively after these awake cases, having not undergone a general anesthetic. So I tell everyone that I operate on using general anesthesia, it's going to be about 2 weeks before you have your normal energy level. This comes back a lot quicker after doing awake cases. So there are more reasons than just localization or examination of function to do awake craniotomies. So for intraoperative tips, again, I stop the hypnotic just prior to performing the craniotomy so that they're wide awake when it's time to open the dura and begin testing. Lidocaine subpledgets for the dura. I examine the patients during the cannulation. So as I'm cannulating, we're always doing some of the exam because often the function may be affected by the cannulation. As far as seizures, of course, keeping some ice saline close. It's in general less of an issue during these cases. Most of your manipulation is going to be subcortical. I play music the patient likes during these cases. So I ask them all, what type of music do you like? I play that at a low level. It's very calming during the operation. I know it's calming for me to play what I like, when patients are asleep, but I play what they like during these awake cases. I talk to the patient continually during the case, tell them what I'm doing, what's going on, and ask them what they're feeling or what changes they may be noticing. So it's a continual conversation during the case. In cortical and subcortical monitoring, this can help to avoid deficits as you're resecting. So doing that stimulation before resecting, this goes about, 3 or 4 millimeters deep. So I advance about 3 or 4 millimeters at a time when I'm near critical structures or critical areas. Few pearls, of course, selecting the right patient for the case, keeping the patients comfortable during the operation is very important. Frequent testing during key portions of the case, limiting the number of people in the room, because the more people you have in the room, the more conversations start up. And I have to tell everyone, have to be quiet during these cases or only have relevant conversation. Have your team for doing these cases, both anesthesia, or the flies in here have been terrible, and other people that are comfortable during these cases, thinking about what's going on during a wake case, adjustments that they need to make. When everyone's comfortable, the patient's more comfortable, you're comfortable during doing these cases, and it just becomes part of your routine. So, thank you all very much. And happy to take any questions. Yes.
Thank you very much for such a personal view of I still think it's a complex procedure. So thank you very much. And I would like to ask you two questions. The first one is, for example, in my case, I work with different anesthesiologists, and some of them are very happy, and I couldn't agree more with the triple awake. It's much quicker with the next method. I mean, the patients are amazing. But for the anesthetists that are not very happy with that, I'd like to do like a kind of an LMA kind of first phase of the awake. Would you ever consider do the cannulation before awake the patient, or you always do the cannulation with the patient awake? Because I'm always a little bit concerned with waking up with the cannula.
Yeah, I always have them awake before the cannulation, during the cannulations. I think that's really a key part of the operation. They do very well with it. We don't see significant changes in ICP during cannulation, so I'm really not concerned about them being awake during that part of the case. The more time they spend awake during the operation, the more comfortable it is for me. There's always that anxiety with the patient under a general anesthetic. What am I going to have at the end of the operation? You don't have that anxiety with them doing it awake, so that the more awake they are during the operation, I think the better.
Thank you. The second question is about the thresholding. I mean, of course, we all know about the classic open awake craniotomy with accounting for the thresholding. How do you select your threshold with such a small opening if, for example, the frontal operculum is not exposed? So how do you know which intensity are you going to stimulate?
We just start very low, say 2 to 4 milliamps, and work up from there. And with doing the subcortical stimulation, so similar thresholds, but simply start low and work my way up.
Okay, thank you.
Okay, you're welcome.
Ron, thank you. In the example you showed, I assume that the patient was English as their primary language.
Yes.
And so I'm curious if you could comment on primary versus secondary language paradigms. And then a second question I had is utility of awake motor mapping subcortically versus subcortical stimulated EMG with the patient asleep.
Okay, as far as primary and secondary languages, usually we always have someone there that speaks the primary language, because of course the localization of these can be different. So we'll have someone speak to them in English and in their primary language, and note if there are any differences between the two, both when we start during the case and when working. What we found is if you don't have changes in one, surprisingly often there aren't in the other. And I think it has to do with the localization being in slightly different areas. And I'm sorry, repeat, what was the second question again? Yes. You know, for these, since I have such a small opening, you know, we generally don't do much awake motor mapping unless I'm right adjacent to motor cortex. And then I have a very small area that I can stimulate through. So most of it will actually do subcortical. And some of that comes from looking at the articles during awake craniotomies where most of the deficits seen were from the subcortical work rather than actually damage to the cortex itself. So I'm a bit less concerned with the cortical motor mapping than really the subcortical stimulation during the case.
Ron, I wouldn't expect so, but have you ever had a case if you're, especially maybe if you're near the internal capsule of the patient feeling the stimulation? Have you ever had that induce a seizure? What kind are you using? I assume a single shaft monopolar stimulation.
Yeah, it's using a single shaft monopolar. I haven't had anyone develop seizures during the case. I've had a few that have said they felt something during the stimulation, but it's usually been kind of a vague sensation that they get, nothing that they can really define well, but some of them do notice it. But I'm always prepared to treat seizures if necessary during the case.
What's the maximum you've gone up to? Have you gone up to 10 or you stay, as you said, 2 to 4 or 5?
Generally 2 to 4, a couple times maybe up to 8 at the most, but usually stay pretty low. Yeah.